Assalamualaikum warahmatullahi wabarakatuh, and good morning to all. Next lecture will be on clinical practice guideline on NPC. The outline of this presentation will be on epidemiology, risk factors and clinical presentations of NPC, baseline investigation, histopath and cytology. Next will be on radiological investigations and staging, and then treatment on primary NPC, recurrent NPC and also advanced NPC, and supportive management of. So we start on epidemiology, risk factors and clinical presentations of NPC. This booklet on management of NPC you can download from the internet, which is published in 2016. NPC is an epithelial malignant tumor of nasopharynx, which is common among Chinese. The incidence rate of NPC worldwide is about 1 in 100,000 of people. Men are more affected than women. Geographically, Southeast Asia, Southern China, and North Africa have the highest prevalence of NPC. In Malaysia, it has become the fourth commonest cancer, and in males, it becomes the third commonest cancer. The male and female ratio is 3:1. There is a bimodal peak where the smaller peak is at a younger age group at around 6 years old, and the bigger peak is at around 40 to 60 years old. Chinese make about 49% of NPC cases in Malaysia, followed by the natives of Sabah and Sarawak, which is 28%, and Malay, 22%. Among the people in Sarawak, the high incidence is among Bidayu. The risk factors are, the first is infection. One is at increased risk of NPC if tested positive for EBV antibodies. It is also increased if someone has strong family history, especially first-degree relative, compared to those without family history. Smoking also increased the risk to 1 to 2%. Other risk factors are salted fish, especially if consumed since childhood, domestic wood cooking fires, occupational solvents, and also wood dust. Okay, this is an endoscopic view of the nasopharynx via the right nasal cavity. You can see an obvious mass which is ulcerating and bleeding. Laterally is a right eustachian tube. Anteriorly is a floor of right nasal cavity and the septum. This diagram shows how the tumor from the nasopharynx invade the adjacent structures. If you can see, if it invades laterally to the eustachian tube and cause blockage of the eustachian tube, it then manifests as serous otitis media. So the symptom will be tinnitus, conductive hearing loss. And if it goes anteriorly to the nose, it can cause nasal obstruction, and if it bleeds, causing epistaxis. As it goes to the orbit, it can displace the eyeball and cause proptosis. Now, if it goes retropharyngally to the retropharyngeal nodes, it can cause neck stiffness and pain. If it goes into the parapharyngeal space, it can affect the lower 4 cranial nerve, that is cranial nerve 9, 10, 11, and 12, causing cranial palsy, hypoglossal nerve palsy, causing Horner syndrome, and if it goes to the infiltrate the pterygoid muscles, it can cause symptoms such as trismus. Okay, now if it goes into the base of skull, into the foramen lacerum and ovale, it can cause ophthalmic symptoms and facial pain by involving the cranial nerve 3, 4, 5, and 6. Okay, that's the T classification. Now, go to the N classification, to the cervical nodes. It can invade the upper jugular and posterior triangle nodes, causing enlargement and cervical cervical nodes metastasis. And the M status, distant mets, it can commonly go to the lung, liver, and bone. Okay, these pictures shows involvement of the cervical nodes, which can be unilateral initially and then progress to become bilateral. Typically, it is painless, and painless neck lump makes about 80% of the presentations of NPC. Okay, figure 2 shows recurrent NPC with lymph node metastasis, and it looks here that the lymph node is started to become fungating. If you see the next picture, patient has neck lump, and he also shows trismus, which is limited mouth opening. In this picture, you see patient has ptosis of the right eye. And this picture shows NPC patient with ophthalmoplegia, left 6 nerve palsy. Left lateral rectus muscles is impaired, so patient would complain to you with diplopia. This picture shows right hypoglossal nerve involvement, so when patient protrudes his tongue, it will be deviated to the right. See the right sided neck lump. And this picture shows fungating cervical metastasis. So as recommendation, you should refer patients to ENT as soon as possible if they have symptoms such as painless neck lump, blasting nasal discharge or saliva, unilateral ear block or hearing loss, unexplained headache, facial numbness, and diplopia. Next, we go to baseline investigations, histopathology, and cytology. Okay, when we have patients presenting with cervical lymphadenopathy, first of all, we need to assess the entire head and neck for the primary tumor. And then for the cervical nodes, we do FNAC, fine needle aspiration cytology. Try not to do any biopsy such as incision biopsy or wedge biopsy or any kind of biopsy to the neck, because that might cause seeding of tumor cells to the skin in case it is metastatic carcinoma. For the mass in the nasopharynx, we will take punch biopsy and send it for histopath examination. Okay, this is a histopathological grading. Previously, long time ago, used type 1, type 2, and type 3. Now, since 2005, we are using a classification of keratinizing squamous cell carcinoma, non-keratinizing carcinoma, which can be differentiated or undifferentiated, and the third type is basaloid squamous cell carcinoma. Nasopharyngoscopy should be performed in all patients suspected of NPC. NPC should be diagnosed by histopathological examination of the nasopharynx, so we take a punch biopsy of the mass in the nasopharynx. In patients presenting with cervical lymphadenopathy, full head and neck assessment and FNAC examination of the node should be done. Okay, next we go to radiological investigation and staging. MRI is superior to CT scan in demonstrating soft tissue involvement. It is more sensitive than CT scan for skull base and intracranial tumor infiltration, as well as identification of retropharyngeal lymph node metastases. MRI is able to depict not only primary cancers that cause an obvious local mass or infiltration outside the nasopharynx, but also those early cancers that produce only mild thickening of the mucosa. It is also accurate for patients with submucosal involvement which are not detected by endoscopy. Okay, what is the function of PET scan? It is the best modality for diagnosis of local, residual, or recurrent NPC compared with CT and MRI. So basically, we use PET scan for tumor restaging in patients with residual NPC or recurrent NPC. However, in our local setting, CT scan is widely used to stage NPC in view of limited availability of MRI and PET scan. CT scan is also offered when there is contraindication for MRI. This table shows the UICC AGCC staging system. The 7th edition was published in 2009. The 8th edition was published in 2017. The adjustment are mainly at the T classification. At the nodal classification, there is no more 3A and 3B, which is supraclavicular involvement, it has become only N3, which is more than 6 centimeters and or below caudal border of cricoid cartilage. All NPC patients should be staged according to TNM system. The preferred imaging modality is MRI for local and local regional staging. PET-CT scan is for distant metastasis in NPC. For restaging of residual and recurrent NPC, combination of MRI and PET-CT should be used. But when these two imagings are not feasible, CT scan is an alternative imaging modality in NPC staging. Okay, this is T1 radiological staging. You can see the tumor is confined to the nasopharynx. This is T2 tumor with parapharyngeal extension and soft tissue involvement. This is T3 where the tumor has involved the bony structures of the skull base and vertebra. T3 where the paranasal sinuses are involved. Okay, this imaging shows the tumor has extended via foramen lacerum and ovale and has invaded cavernous sinus. Okay, this shows tumor extension into the right orbit. Okay, this is T4 staging where the tumor has extended into the masticated space. Patient would present with trismus and possibly headache. This is tumor involvement of the trigeminal nerve and patient might present with facial numbness. This is a tumor extension into the hypoglossal canal. Patient might present with the tongue deviated to the left. Okay, so hypoglossal nerve palsy might be the only presentation in NPC. N1 staging is nodes of the size of less than 6 centimeters unilateral. In this case, it's left side neck nodes. N2 staging is cervical lymph nodes of less than 6 centimeters but bilateral. N3 is cervical nodes of more than 6 centimeters in size, regardless whether it's unilateral or bilateral. Okay, now we come to the treatment of NPC. NPC is radiosensitive tumor, so it responds very well to radiation therapy. That is why the mainstay of treatment of NPC is radiation therapy with or without chemotherapy. Chemotherapy, however, can be given as concurrent, adjuvant, or neoadjuvant setting. Radiotherapy is usually given in 33 to 35 fractions. Each fraction is 2 gray, which is why it usually consists of 66 to 70 gray, which is given over the span of 6 to 7 weeks. Previously, 2D RT was used. Now we are using 3-dimensional RT. More intensity modulated radiotherapy, which is IMRT, are being used. The good thing about IMRT is that it can deliver high doses of radiation to the cancer cells, but sparing vital structures nearby, such as salivary glands, optic apparatus, spinal cord, brainstem, and pituitary gland, so can reduce and minimize complications. It also improves local control and progression-free survival for both early and advanced cancer. Okay, this shows the dose distribution of IMRT with sparing of normal structures compared to the 2D technique. This shows significant reduction in symptoms such as xerostomia post-RT. For newly diagnosed NPC patients in stage 1, radiotherapy alone is sufficient. But for stages 2, 3, and 4, we need to give them concurrent chemoradiotherapy. The preferred technique of radiation is IMRT. Next is the treatment for recurrent NPC. It depends on where the recurrent tumor is, whether it is at the primary site at the nasopharyngeal area or at the secondary site namely the cervical lymph nodes or distant metastases. 95% of recurrence occur within 3 years after completion of radiotherapy. For recurrent NPC at the nasopharyngeal area, depending on the T staging, for T1 and T2, we might offer endoscopic nasopharyngectomy or brachytherapy. For T3 or selected T4, conventional nasopharyngectomy might be offered, or maybe we offer re-irradiation. For secondary recurrence in the cervical lymph nodes, usually we do radical neck dissection. Re-irradiation would be limited to the previous radiation treatment dose and normal organs tolerance. Okay, next we go to the treatment in advanced disease of NPC. The treatment option for advanced disease NPC is basically chemotherapy and radiotherapy, but this is actually for palliative intent. Patients receiving either chemotherapy or RT have better 1-year overall survival rate compared with those without treatment. Other than chemotherapy, radiotherapy, and in certain case surgery, we have to focus on patients' quality of life by supporting them with spiritual needs, nutrition supports, pain control, and psychological and social supports. You can only consider patient for palliative chemotherapy if their performance status is of 0 to 2 only. Okay, 0 is fully active, able to carry on all pre-disease performance without restriction. Grade 1 is restricted in physical strenuous activity but ambulatory and able to carry out work of light or sedentary nature, such as light housework or office work. Grade 2, ambulatory and capable of all self-care but unable to carry out any work activities, and patient is up and about more than 50% of waking hours. Beyond that, patient is deemed not fit for palliative chemotherapy. NPC patients need dental assessment before they go for radiotherapy. If they need dental extraction or scanning, that has to be done before radiotherapy started. As a result of the tumor itself in the nasopharynx or a side effect of radiotherapy, patient might develop otitis media with effusion, that is fluid accumulating in the middle ear. So patient might complain of hearing loss, conductive hearing loss. To extract the fluid out, we might do mingotomy alone, or we can insert grommet to continuously take out the fluid from the middle ear. However, the complications of putting grommet is causing a chronic ear discharge. So the other alternative is by giving hearing aid to increase the patient hearing threshold. For female patients still undergoing treatment, we would advise intrauterine or implantable contraceptive and try to avoid combined hormonal contraceptive method, which contains estrogen and progesterone. This should continue for at least 6 months after completion of treatment in order to avoid venous thromboembolism. Nutrition is very important for cancer patients because they are in catabolic state. We have to make sure that the calorie intake is adequate. If it is not enough, we have to supplement them with milk, such as Ensure, Anucal, or Pastil exposure, which is specifically designed for cancer patients. The common oral complications of radiotherapy are xerostomia, which is dryness of the oral mucosa, mucositis, which usually occur from 3rd to 4th week after beginning radiotherapy, and candidiasis. Mucositis can be really painful, so this hinders patients from taking orally, so they might be insufficient in their oral intake. So we need to give them really good analgesic to overcome this. Xerostomia can be treated with pilocarpine. Otherwise, patients need to take frequent sips of water. Osteoradionecrosis is one of the complications of radiotherapy that is difficult to treat. It can be controlled by sequestrectomy combined with hyperbaric oxygen in majority of NPC patients. In some extensive cases, might require radical sequestrectomy with microvascular-free flap reconstruction. Long-term antibiotics are needed. For follow-up, clinical examinations of the nasopharynx, including an endoscopic examination to detect superficial tumors, is required. So for the first 2 years, we see patients every month. We also need to check the neck for the recurrent neck nodes and other systems for distant metastasis, mainly to check the lung, bones, and liver. If you need to do cross-sectional imaging post-radiotherapy, it should be offered no earlier than 3 months. Cross-sectional imaging as needed is to detect deep infiltrating tumors not associated with mucosal lesion during the initial 3 to 5 years post-treatment. Okay, now we have come to the end of this lecture. You can download the Management of Nasopharyngeal Carcinoma booklet, the full text PDF from the internet, and have a further reading on it. With that, I thank you.